Thanks for turning up, everybody, today. I'm Nadine Beydoun. I'm one of the radiation oncologists here at St George Hospital. I also have a private practice at Genesis Cancer Care at Hurstville, and I'm a conjoint lecturer at the University of New South Wales. I don't really have any disclosures apart from that I talk very fast. Those of you who know me would know that. So I'm going to launch straight into a case scenario about a patient of mine who was diagnosed with rectal cancer and had some treatment some time ago. Now, I apologise that the room setup is not quite conducive to an interactive discussion, but I am going to be sort of opening up some questions to the floor and asking you what you would do with this scenario. This is a 78-year-old gentleman who basically presented to you with iron deficiency anemia. He'd been mildly constipated for a long time, but more significantly so in the last 6 months. And he'd also more recently noticed some intermittent bright red colorectal bleeding. He's otherwise a pretty fit gentleman for his age, on cholesterol medication for high cholesterol, but not much else really. He's very highly functioning, independent. He is widowed and lives alone, but he's got very supportive children, including an adult son who lives nearby. So he is at ECOG performance status 1 because he's symptomatic of his problem. But other than that, he's actually quite a well gentleman. And no family history, I must say. So what would you, as a GP in your practice, do next?
Check the full blood count, set the blood test.
Okay, so full blood count is useful because we're looking for anemia potentially because he's bleeding and the severity of the anemia. Other blood tests that are useful? You talked about CEA levels. Do you think they're useful as a broad screener of rectal cancer? Yep.
Constipation with an X-ray.
Yep.
To check if there's any lump or anything.
Mm-hmm.
And if there's any suspicion, abdominal CT scan or anything like that.
Okay.
And the PR?
Yeah, so basically you investigate the history, you ask more about the symptoms, and the severity, if they've lost any weight, so constitutional things, comorbidities, which we know, but also leading on to the physical examination, importantly a digital rectal examination. Is a fecal occult blood test useful at the moment?
No.
Yes, no,
Yes.
mixed?
Yes.
Okay. Is it going to change what you do? Not really? Yep. So do you have a high index of suspicion that this gentleman has a problem? Yes, so
hemoglobin of 67.
yeah, so basically what actually happened is his GP sent him to emergency because he was pre-syncable, he was tachycardic, feeling lightheaded, and when he had blood tests done through emergency, his hemoglobin was actually 67, so he went on to have a blood transfusion and then proceeded directly to fecal occult blood test? No, colonoscopy, yes. So at colonoscopy, he was essentially found to have a low rectal tumour, quite extensive and circumferential, and the surgeon biopsied that area, and the biopsy came back with moderately differentiated adenocarcinoma. So that's what his actual scope looked like. You can see quite abnormal in the rectum and very circumferential hemorrhagic mass, and not much lumen left in the rectum. So what other information do we need now to sort of make decisions about how we're going to care for this gentleman with a confirmed rectal tumour?
For some reason,
Oh, you need the answer. Maybe I should. Look away, perhaps.
PET scan of the abdomen?
PET scan.
Sure.
So anybody else think a PET scan is useful?
Just an abdomen CT scan.
Okay. So yes, we normally start off with a CT of the chest, abdomen, pelvis, and that's part of the completion of the staging. So we're looking for metastatic disease, nodal disease, liver, lung metastases. Okay, that would be the standard. Now, in terms of PET scan, the difficulty with PET scan is that for localised rectal cancer staging, it's not actually a funded investigation. So we're allowed to, use PET scans for people with, for example, previously treated rectal cancer who have suspected relapse or metastatic disease, recurrence. In that setting, we're allowed to order a PET scan, but at the outset, it's actually not funded, so there'd be an out-of-pocket expense if we were to do it. And that's, I guess, an important thing to consider in terms of cost and benefit. So the accepted imaging modalities, as we mentioned, would be the CT of the chest, abdomen and pelvis. And the other important imaging modality, which Winston mentioned in his talk earlier for rectal cancer specifically, is an MRI of the pelvis. So that is actually a funded investigation. People are allowed an MRI of the rectum as part of staging. And that's very, very important because it's really what helps to dictate whether patients require preoperative treatment. Sometimes also it might impact on the kind of operation that they have. Postoperative treatment as well often is based on their preoperative imaging stage, which is, the MRI. So this gentleman did have an MRI and a CT. The CT showed an irregular concentric rectal mass. So difficulty is CT is not very useful for staging, for the T stage of rectal cancer, so it's mainly used to assess for metastatic disease. But the MRI in this gentleman showed a semicircumferential tumour. It was 4 centimetres from the anal verge, so we do look at distance, as I said, because it's important in terms of working out whether this patient's going to have an anterior resection or an abdominoperineal resection, which are very different operations, and there's lots of lifestyle implications if you have to have an APR and a permanent stoma. The thing that we look at as well is the size of the tumour and the depth of invasion through the actual rectal wall in terms of predicting whether these patients can go straight to an operation or need some preoperative treatment, either to downstage or just really to maximise local control. And the MRI is also very useful at looking at nodal disease within the fat around the rectum, but also in the pelvis and beyond. So this gentleman was found...
So
yes.
should a GP organise an MRI pelvis?
Usually at this stage, and this gentleman, as I said, has been admitted to hospital, it would normally be that the colorectal surgeon or sometimes even the oncologist, once a patient's been referred and been diagnosed by the colorectal surgeon with the cancer, that would organise the MRI scans. Most of the patients that I see in my practice would already have had that workup of the MRI, often by the surgeon, as well as the CT scan. Occasionally I do have to do the MRI myself. So this gentleman essentially was staged as T3 and 2 on the basis that he had multiple mesorectal nodes involved. He also had some pelvic sidewall obturator nodes that were abnormal looking on the MRI scan, and quite deep penetration through into the mesorectal fat makes him T3 disease. I don't know why it's backwards, I apologise for that. This is his actual MRI scan, so you can see here that the actual rectal wall, there's penetration beyond the actual rectum towards his actual coccyx. So this guy is a good going T3 tumour, and perhaps you could argue also T4 disease potentially. So he's got quite deep invasion into the rectal fat on that MRI scan. Yes.
Just speak up a bit. We're missing a lot of what you're saying.
Okay, no worries. Stay closer to the microphone. So you can see on that MRI scan that this gentleman has penetration, full thickness of the rectal wall into the fat around the rectum. At this level it's called ischiorectal fat, so it's a continuous flat plane. Higher up it's called mesorectal fat, lower down it's ischiorectal because this guy has a low rectal tumour, and extending all the way towards the coccyx there. And that's the sagittal view again. You can see here normal rectum but low down, quite a bulky tumour, and extending posteriorly towards the tip of the coccyx, as you see. So going back to those investigations, I've already mentioned that PET scan wouldn't ordinarily be used. This guy, the advantage of being an inpatient is that he did get a PET scan. The CEA level is useful, I guess, as a once you've diagnosed rectal cancer, to look at elevations and beyond for monitoring. So if a patient does have an elevated CEA level once you've diagnosed their rectal cancer, it can potentially be a useful marker long term at monitoring them for disease recurrence. Whereas if it's non-elevated from the outset when they've been diagnosed with rectal cancer, it's not really going to be a useful monitor long term for recurrence as well. And so the other blood tests that we also talked about in terms of pre-treatment, looking at their liver function as a broad screener of metastases, but also implications for systemic therapy as well as kidney function. This is the gentleman's PET scan, and you can see here that he had a number of mesorectal nodes as well as extensive uptake in the primary tumour, so quite locally advanced disease, but no evidence of metastases on the PET scan. So, how many of you would refer this patient on, or how many of you believe that this patient should go directly to surgery?
How many what?
You can have some pension
How many of you
therapy
believe that he
for
should have an operation?
No.
No. Why not?
Should have some adjuvant therapy, like either radiotherapy or chemo.
Some preoperative treatment, neoadjuvant, yeah. Any takers for direct surgery? No? Okay. So I guess I would say that this patient should ideally be brought to an MDT so that we can review his imaging, confirm his actual stage, and have a collaborative decision as to what's going to be the best approach in terms of treating this gentleman, rather than practicing in silos. So I'm going to go through a little bit about my job and when we do give people preoperative treatment, because preoperative treatment often implies radiation treatment, and there are a number of ways that we can give that radiation treatment, and there are nuances as to which might be better and which we choose, even though the data seems to suggest that, you know, the two recipes, the long and the short, are quite comparable in terms of outcomes. So generally anybody with locally advanced disease, so a T3 or T4 tumour, so full thickness penetration of the rectal wall into the fat or even beyond into adjacent structures like your bladder, your prostate, seminal vesicles, those patients would benefit from preoperative treatment for downstaging, but also to maximise pelvic control rates. And also anybody with nodal disease within the mesorectal fat, again, because the data seems to suggest that these patients have a higher risk of pelvic recurrence. We also often, unfortunately, see patients in the postoperative setting, so who have positive margins, and in those patients we would consider, of course, postoperative radiation along with chemotherapy. So as I mentioned earlier, if we are giving them radiation treatment in the preoperative setting, there are different ways of doing it. One is essentially a short and sweet regimen, just what we call short course. It's 5 sessions of treatment daily, so over a week, and patients usually proceed to their surgery within a week of that, so 5 to 7 days later they have their surgery, so it's quite quick. And I guess there are advantages to that, which is that surgeons want to operate, and it means that they don't have to wait too long to operate. And also it means that the patient's treatment is done with relatively quickly, so you don't actually expect them to experience a lot in the way of treatment complications from the preoperative radiation course. It's quite different to the long course of treatment, which is actually a 6-week regimen of daily treatment combined with chemotherapy, often infusional 5-FU or tablet chemotherapy with Xeloda. And in that situation, patients don't proceed directly to an operation. They often have to wait at least another 6 to 8 weeks before they have their surgery. So it's a very long and arduous course, and you'd expect that in that time they are going to run into issues with side effects as a result of that concurrent treatment. And of course, those patients that we don't see preoperatively but have locally advanced disease, we do occasionally see those patients and would treat them in the postoperative setting. Not ideal, but of course you do want to maximise local control rates, so we do it. So I guess, why do we give people preoperative treatment and make a decision about short or long course? Well, historically and decades ago, we used to sort of see very, very high pelvic relapse rates, depending on the surgery that was done. That's what we call the pre-total mesorectal excision era. So essentially, historically, rectal surgery was blunt dissection of the rectum and not a lot of removal of the fat around it, and often that meant that recurrence rates were woefully high, over 30%. And in the last couple of decades, the newer surgery, the total mesorectal excision, was introduced, and that definitely did reduce pelvic recurrence rates. But we also still know that even with that surgery, there are people with higher risk factors that can still have recurrence rates of 15 to 20% in the pelvis, those with nodes that are involved, those with T3-4 tumours. And some of the work that's been done in randomised trials from the Swedish, German groups, as well as a number of other European centres, has looked at giving people preoperative radiation treatment as compared to surgery alone, and we know that the radiation treatment can more than halve those pelvic recurrence rates. So there's a significant benefit in terms of pelvic control with giving them preoperative treatment. Some of that earlier work was giving a short course regimen, so essentially 5 by 5 days of radiation and then proceeding directly to an operation. One of those very earlier studies also showed an improvement in survival if you give radiation treatment, but I guess the criticism about that study was the fact that the surgery wasn't high quality total mesorectal excision surgery. It was the older style surgery, the blunt dissection, and so that the surgical group had higher recurrence rates. So the argument there is that the radiation kind of was compensating for poorer surgery. The more recent studies looking at preoperative treatment haven't shown a survival benefit, but certainly local control that's more than halved. So, I mentioned the short course regimen, short and sweet. When do we choose to use the long regimen, the arduous combination with chemotherapy and 6 weeks and then waiting at least another couple of months before we operate on these patients? Well, really, if you've got a patient like my patient who's got T3-4 disease extending out towards the coccyx, you're going to be very concerned about resectability of the tumour if you're essentially giving them a short course of treatment and then operating on them immediately. You're likely to end up with a positive margin. And what we do know from the studies that look at giving people preoperative treatment and going to surgery is that if they've got a positive margin, they still have very high relapse rates and poorer outcomes as a result. So really what you want to try and do in these patients is downstage their tumour, and the only real way of doing that is not to operate on them immediately, is to actually give them a low and slow recipe, wait until the tumour is been maximally downstage, and then to operate on them. And I guess also radiation is a bit like real estate, so location is very important. If you've got very low tumours and borderline, 3-4 centimetres from the anal verge, where a patient really doesn't want to have a permanent stoma and they're looking at an abdominoperitoneal resection if they go directly to surgery or only have a short course of treatment, those patients may actually benefit from downstaging and conversion of their abdominoperitoneal resection to an ultra-low anterior resection, and meaning that they might have a temporary stoma but not necessarily a long-term stoma, and that's a huge thing in terms of quality of life for patients. And I've certainly had a lot of patients who just flatly refuse surgery because the implication is a stoma and they just do not have a permanent stoma. Now, I did mention that unfortunately sometimes we don't get the luxury of offering patients choice. Yep, sorry.
Yeah, do those people that are having the long preoperative treatment, do they have to have a stoma?
So it really depends. So Winston mentioned that sometimes we actually do electively do defunctioning colostomies on people pre-treatment, and often that's something we consider in people who, for example, have quite significant obstructive symptoms and we're concerned how they're going to fare for 6 weeks for treatment, and then another 6 to 8 weeks beyond in terms of the bronchitis and all of that. So those patients may have defunctioning stomas to help them along and get through the treatment. And the other group of patients that we often consider defunctioning stomas in pre-treatment are those that we also are concerned are going to struggle in terms of symptoms and proctitis. And of course, having a bag that you might empty more often because diarrhea is a very common complication of treatment is a lot more palatable to patients than having copious motions through an area that's sore and there's bleeding and so on. So often we would push the surgeons for a defunctioning stoma to help people get through that treatment, and it's actually a much more feasible way to get them through that long course of treatment. So that's when we do it electively. But of course, the other interesting thing, for example, one of these studies that I mentioned earlier, the Polish trial, looked at essentially long course treatment for downstaging. What's interesting is that the actual surgeons didn't change the operative procedure that they planned on doing initially. So if they decided a patient needed an APR, despite the downstaging, that patient would still get an APR. Now, anecdotally, I know that our practice since then has obviously evolved, and we certainly do have changes in the type of operation, and a lot of that is driven by patients because given the choice, obviously most patients would prefer not to have a permanent stoma. So sorry, in terms of pre versus post-operative treatment, why we sort of try and avoid giving people post-operative treatment, I like to see them beforehand, because, well, firstly, it's a lot harder when you're waiting for people to recover from a big operation to give their treatment in a timely way, and also it's a lot harder to get them through that treatment. And certainly we know from the randomised data that toxicity is worse when you're giving it postoperatively, and it's not as efficacious in terms of local control. So there are a number of reasons why we just don't like it. Now I do want to get onto radiation and how we give it, because I think radiation is a very taboo specialty, and a lot of disciplines don't know what we do in our laboratories and so on. So one of the first thing that we would do when a patient comes for preoperative treatment is essentially we'd have to image them, set them up in the correct position. We have certain protocols for how we treat people. One of those, importantly for rectal cancer patients, is that they have to have a full bladder every day for treatment, so that all the bowel is pushed away from the high dose radiation region, and therefore mitigating bowel toxicity. But also, I always tell patients, if you've got a bladder the size of a pancake, all of it's going to be irradiated, which means their long-term cystitis rates are much more significant than when you've got a full bladder, and it means only a part of that bladder is going to be in the radiation treatment region. We do not only just treat the actual tumour, of course. We've mentioned that many of these patients will have involved nodes, so we treat all of the at-risk nodes, those within the mesorectal fat, but essentially all of the pelvic nodal draining regions as well, and they're very well described in some of our international protocols. The doses that we use, as I mentioned, for the long course is 5 weeks of treatment plus then a boost to the actual tumour itself. And we have very set guidelines as to what we accept in terms of tolerance to some of our nearby structures, the critical ones being the bowel, the bladder, your pelvic bones as well. And if they're having long course treatment, often these patients would get infusional 5-FU, realistically most of them these days, just because of ease of administration and practicality, they usually get oral capecitabine, so tablet therapy. And most of the surgery is undertaken 6 to 8 weeks, but more and more these days surgeons are actually pushing that out even further, up to 12 weeks, because there is good evidence to show that you get maximal downstaging if you wait that long. And there's also quite a lot of work these days at looking at a non-operative approach, so essentially trying to downstage those patients who you're trying to avoid surgery in, and occasionally some people will actually get a pathological complete response. So the literature seems to suggest that with long course treatment, about 15 to 25% of people will actually have no tumour at the time of surgery. So in those patients that are borderline for surgery, sometimes our colorectal surgeons will advocate for them to have long course treatment and essentially second look and avoid having a big operative procedure at the end of it. So this is our poor patient being mapped by a lovely radiation therapist coming in for their tattoos. And this is them on our treatment couch. So you can see here, this is our linear accelerator. It's all about accuracy, but it's not an invasive treatment. The machine doesn't touch them, but they are in the room by themselves when the treatment is being delivered. This is, believe it or not, how radiation started when I was a trainee. So essentially it was a plain film. We had crayons and we drew on our radiation fields, and everything within that area that I've drawn essentially got the radiation dose through and through. So you can imagine the level of toxicity that you'd experience, and believe it or not, there are some centres that up until a few years ago would have still been practicing this style of radiation treatment. Now, of course, since then we've got a little bit more sophisticated. We've got to keep up with our medical oncology colleagues with their fancy drugs. So it's all CT-based planning, and anatomy is very important as a radiation oncologist in terms of mapping out all the nodal drainage basins and contouring those and planning your radiation around those areas. But also important, you can see that if you're marking out all of these areas for treatment, how all the normal tissues will still get some radiation dose. It's not possible to avoid them completely. That's just looking at what we actually target in terms of location of the tumour and the nodal drainage areas that are targeted with radiation treatment. This is this gentleman that we were actually discussing. So this is what it actually looks like once we've mapped out his radiation treatment. You can see the khaki there is the entire target volume of radiation, and there's also a smaller area where we deliver a boost to the tumour itself for the final part of the treatment. Fortunately for him, he had a whopping sized prostate, so his bladder was pushed quite anteriorly and out of the radiation field, but in most circumstances that wouldn't be the case. The bladder would essentially receive, a lot of that radiation dose, and people are commonly experiencing acute cystitis and possibly also late cystitis as a result. And before approving any plan, a radiation oncologist will always look at some of the parameters for some of these organs at risk: your pelvic bones, your bladder, genitalia, and the small bowel, importantly. And there are respective tolerances that we know to always abide by. This is the patient through treatment delivery. So we don't only lay the patient on the bed and hope that the treatment is delivered accurately. We actually do image and make sure that internally all our structures line up as well, so that it's a quality assurance exercise for us every day. Now, talking about toxicity, so we've mentioned that there are a lot of critical structures in the pelvis. Some of the things that people, and this is mainly for the long course, as I mentioned, with 5 sessions of radiation treatment, the treatment is done with so quickly that most patients don't even experience acute proctitis. Very occasionally a bit of nausea and maybe some diarrhea on treatment, but beyond that, not much else. So it is attractive to the surgeons, the short course treatment, because it's minimal acute toxicity. But for the long course treatment, it is a protracted course, so patients do experience fatigue. They'll get a skin reaction, particularly around the perianal region, hair loss, diarrhea, both because the radiation targets the bowel, but also because our chemotherapy regimen also tends to cause diarrhea. And they do get urinary symptoms, as mentioned, because their bladder and urethra are in the treatment area. For our female patients, they can get vaginal irritation as well, and proctitis, obviously, because we're treating the rectal tumour, we're trying to burn the tumour. And in terms of late effects, some of these things can translate into long-term issues. One of them that's important is sexual dysfunction, and it's very important. I always talk to patients about that issue, but for them to understand that it's not just a radiation complication. A large proportion of that is a result of their surgery as well, mainly because the actual nerves that are responsible for sexual function are quite robust in terms of the radiation doses that they tolerate. So, and the doses that we use to treat rectal cancer generally are below that. So the actual injuries is less so a neurovascular one from radiation as it is as a complication of their surgery. These patients are always going to be at slightly higher risk of bowel obstructions and perforations because everything's sticky after radiation and operation. And for those of patients who have very low tumours, I always tell them, and are looking at trying to avoid a permanent stoma and have an ultra low anterior resection, I always also tell them that occasionally sometimes function may be an issue, because when we irradiate these people's sphincters with very low tumours, their actual long-term function is not very good. And I've often had patients who have such a miserable time after their reanastomosis with rectal urgency, with incontinence issues, with loose motions and frequent motions, that they sometimes decide that, well, actually perhaps I'd better go back and have a stoma because my quality of life is just not very good. I can't go out because they're on antidiarrheals. So sometimes that is an issue. And of course, the altered bowel function, as Winston mentioned, they're never going to really have normal bowel function. There's going to be a degree of abnormality, have sensitive foods that they just can't eat because that makes them go to the toilet, might need to have antidiarrheas before they go out, that sort of thing. And urinary symptoms. Only about 5% of people, provided that we respect those bladder tolerances, will have long-term urinary urgency and frequency issues. And of course, Winston also mentioned earlier that we do treat some young people with bowel cancer. I've treated people in their 20s, 30s with bowel cancer, and second malignancy is always really important when giving them radiation. That incidence is very low, but when you're talking about a population who are young and also potentially expected to have long-term survival beyond their treatment, then it is still a relevant conversation. So that incidence is about 0.1% after 10 years, and that could be anything from a second malignancy in the pelvis, like a sarcoma or a prostate cancer or a second bowel cancer, to a skin cancer in and around the radiation field. So another reason to monitor these patients long term. Now, just a couple of different scenarios in terms of how you manage toxicity. So 3.5 weeks into our gentleman's long course treatment, he basically presented with diarrhea 3 times a day. He's still maintaining his fluid intake. He looks as though his mucous membranes are a little bit dry, but hemodynamically he's still stable. So if he turned up to your practice as a general practitioner, what would you normally advise this patient? What would be the appropriate course of action?
3 days, 3 times a day is probably still manageable for me.
Are you concerned about this patient? Yes or no? Shaking and
Dehydration.
He's getting fluid.
So maybe he's increase his fluid intake and
Yep.
some mild antidiarrheals.
Yep. Yep. So I think this patient can still be managed in the community. So essentially, yes, oral rehydration and antidiarrheals. And what about the second scenario? So same time frame. So halfway through his treatment, this gentleman says that I'm going to the toilet more than half a dozen times a day. And I get up at night as well. He looks not well, pale. He's got reduced skin turgor. He's hypotensive and tachycardic. Are you concerned about this gentleman? Yeah. Yep, so he needs to go to hospital, possibly intravenous therapy. Yep, and some blood tests. So yes and yes.
With a guy like that, would you be adjusting doses or the course, or are you just going to get him through?
You've got to get him through, yeah. So, obviously, usually, hospitalisation, intravenous therapy, and then we don't really have to admit patients very often who are this unwell. It's often the ones that are sort of slightly poorer, more borderline performance status at the outset that don't tolerate the treatment as well. So you would essentially try to support them through the treatment, so IV fluids, antidiarrheals, but of course beyond that, if they're still struggling with the treatment, then the first thing that would usually happen perhaps is to consider withholding their chemotherapy and persevering with their radiation alone. And then, of course, if that becomes an issue, then you've got to reevaluate whether they can get through that long course of treatment. But to be honest, in most instances, patients will get through at least the radiation component of their treatment if you support them through it. Just the concurrent treatment sometimes can be difficult for some patients. All right, that's kind of the end of my case scenario. Does anybody have any questions or comments? I've just got a slide on follow-up, and Winston talked a little bit about this, and I've kind of put some general guidelines for follow-up that are used, AGITG guidelines in terms of 3 monthly, and I tend to do 3 monthly imaging as well as blood tests to 2 years. Winston mentioned to 12 months and then 6 monthly. And there's a great heterogeneity in practice and in terms of guidelines. I try to see people to 5 years, and they, as Winston mentioned, have a follow-up colonoscopy at 12 months and 5 years. Now, it's very tricky, mainly because guidelines are very, very heterogeneous, but also there have been a number of large systematic reviews as well as meta-analyses that have looked at the issue of how you follow people up with very mixed results. So most recently, I think last year, a meta-analysis in the JAMA looked at frequency of imaging of CEAs and clinical follow-up, and essentially showed that doing CEAs and follow-up and imaging wasn't necessarily any better than just clinical follow-up. So I think we probably do over-image these patients, but it's very difficult as an oncologist because we do see people who, when we detect recurrences early, do better with aggressive management like metastatectomies and early systemic therapy. So it's difficult to gain equipoise there.
If there was a family history though, you'd do follow-ups more frequently than every 5 years, would you?
Absolutely, yeah. So this patient didn't have a family history and he was in his 70s, but of course the paradigm completely changes if you've got a family history. In fact, I've got some resources here, but I just had a couple of slides that, again, of a shared patient of myself and Professor Liao's who was in his early 30s and had a number of ED presentations with bleeding until he was finally, and I think the first scope actually was normal, but clearly not normal. That you can see here, very abnormal, multiple polyps in his rectum, and essentially was shown to have a familial adenomatous polyposis syndrome, so a number of tumours. So he basically had long course treatment for his locally advanced bowel cancer, and he's proceeded on to a total colectomy. So yes, very different follow-up for that group of patients.